Hey everybody, welcome back to the ECG of the day. My name is Reed, and before we get started, don't forget that you can download the PDF of today's ECG document down in the description below. It's linked in the description, and don't forget to like this video and subscribe to the channel if you enjoy the content. So let's jump into it. So the first thing we're going to do with this ECG is we're going to look at the forest, and the trees of the forest are my QRS complexes. And the first thing I notice is I've got if I look maybe here in V5, I've got a narrow complex rhythm that is occurring very slowly but regularly. Seems like maybe this one happens a little bit early when you compare it to kind of the rate that we see, and then we have a resumption of our narrow complex rhythm. You might at first think, well, where are the P waves? I can see a P wave peeking out just there, or you can see a little blip of a P wave throughout some of these leads, not on all of these leads, very low voltage P wave. So it does appear that in this setting of this narrow complex rhythm that there is some sinus activity. Right, we're obviously going to need to figure out what that sinus activity is. Let's determine the rate of this. We know it's going to be slow. I can count the number of little boxes. So if I start here, it's about on the solid line. So 1, 2, 3, 4, 5, 6, 7, 8. So that's 8 big boxes, which is 40 millimeters plus probably 4. So 44 millimeters is my R to R interval. So if I do 100 or 1500 divided by 44 millimeters, I can get my rate, and that rate is going to be 34 beats per minute. So we have a severe bradycardia. And what is our difference diagnosis for this bradycardia? Well, we could have AV block, right? If not all P waves are getting down to the QRS, we could have an AV block. If it was a complete AV block with an escape rhythm, that's typically what you have with an escape rhythm is it stays regular the entire time. But because of this early beat, that makes me think maybe this isn't an escape rhythm after all, especially in the setting of maybe some P waves there in front of my QRSs. We could have severe sinus bradycardia, and you could have an escape rhythm, especially in the setting of this narrow complex rhythm. And so let's see what the atria is doing. First thing we're going to do is we said we have these P waves. Right, we've got these P waves. The P waves are maybe just isoelectric or maybe a hair upright in lead 1. If you look here in AVF, it's so hard to see, but maybe a little bit isoelectric, but I can see that they're upright in lead 2. So that tells me that they're most likely heading down into the left, most likely a sinus P wave. And I look for any extra P waves throughout. I don't see any. Next thing we're going to do is we're going to check out what our AV node function is doing. And so that's going to be this PR interval. I can see that my PR interval appears to be, if I start from this QRS to the beginning of this P wave, my PR interval is maybe 6 millimeters long, so my PR interval looks to be 240 milliseconds, which is a little long. So we do have some type of AV block. And so what type of AV block do we have? We need to make sure that for every P wave there is a QRS, and so I like to scan through all the baseline here to look for any atrial activity. And so I look through all the different leads to see, do I see any extra P waves? And in fact, I don't. In between each QRS complex, it seems to be no atrial activity. So in the setting of every P wave could do QRS, but just taking a little bit longer, this is a first degree AV block. So we've got a severe sinus bradycardia with a first degree AV block. Okay, so that kind of explains our bradycardia. Let's keep working through this. So our QRS complex now, we said we have a narrow complex rhythm that's upright in lead 1 and it's upright in AVF. That tells me that my QRS axis is down and to the left, which is in the normal quadrant here, which is good. I've got normal R wave progression. Seems that my R wave grows, transition around lead V3 to become dominant, which is normal, so that's good. And my QT interval seems appropriate. I don't see a QR or a QT that seems to be wildly prolonged. However, you could calculate the corrected QT in this case. And so now I'm going to look for ischemic changes, pathological Q waves, and ST and T wave changes. And so one of two things comes to my mind when I think of a severe sinus-mediated bradycardia, especially in the setting of an AV block. So one thing could be, is this sick sinus syndrome, SSS for short. Sick sinus syndrome often happens in patients that have a severe burden of atrial fibrillation, right, some paroxysmal AFib, because the AFib, when it's just aberrantly going through the atria, it's constantly overdriving that SA node. The SA node is just being stimulated by all this, fibrillatory waves that are bumping in and depolarizing the SA node. And so what happens is when the person converts from their AFib into a sinus rhythm, their SA node really can't keep up with that fast of a rhythm. So there could be sick sinus syndrome. But my second thing is, could this be a right coronary artery occlusion syndrome? Because the right coronary artery supplies the SA and AV node. And so my eyes immediately go to the inferior leads, right? And my inferior leads are leads 2, 3, and AVF. And so what do we have here? We have, I would say, something called hyperacute T waves. And so what that means is you don't necessarily have massive ST elevation, maybe not ST elevation, but you have T waves that are bulky, right? So hyperacute T waves are bulky. Usually you have a QRS, so it's like QRS, then you have this nice T wave that's proportional to it. But a hyperacute T wave is going to be this bulky. And so look at an AVF especially, we have this little small QRS, but this bulky T wave that has a lot of area under the curve, right? And you have the same thing here. Usually we think that the axis of the T wave should be the same axis as our QRS, but this time it's not. And we've got these bulky T waves, right? The takeoff of the T wave is earlier to create more area under the curve, and you get a little bit less of that here in lead 2, right? A less bulky T wave would be something that would kind of be flatter, and then you have your T wave. That was kind of a bad drawing, but in this case you have the takeoff of that ST segment to make this bulky. So those are hyperacute T waves in the inferior leads. And you also see some evidence of T wave inversions in the high lateral leads, which are leads 1 and AVL. And so you can see these T wave inversions. That's almost the equivalent of reciprocal changes. These are kind of reciprocal T wave inversions of our bulky hyperacute waves, right? And because the inferior leads are down here, we would expect to see reciprocal changes on the other side, which are up here. And so that's kind of what we're seeing, is hyperacute kind of reciprocal changes. And so this is incredibly concerning for an OMI, right, or an occlusion of the right coronary artery. And so there's this kind of new nomenclature that's out there. There's occlusion, myocardial infarction, OMI, and these hyperacute T waves are very concerning for an RCA, right coronary artery. And you put that occlusion of the right coronary artery in the clinical context of this rhythm, we've got this severe sinus bradycardia with a little bit of a first-degree AV block, and so that would match up with this, the anatomy of the right coronary artery, right, supplying the SA and AV nodes as well as the inferior portion of the myocardium. So put this all together, what do we have? We've got a sinus rhythm at a rate of 34 beats per minute, so we have a severe sinus bradycardia with a first-degree AV node block. We've got hyperacute T waves in the inferior leads 2, 3 in AVF with some reciprocal changes, reciprocal T wave inversions in lead 1 and AVL. This is all very concerning for an occlusion of the right coronary artery, which this patient did have, and they did receive a stent, an emergent cath lab activation. So I hope this helps. If you have any questions about this, there are some really good resources online, some great readings. And if you have any questions about what the best resources are for those, feel free to leave a comment, and I can definitely send those your way. So if not, have a great rest of your day, and we'll see you during the next ECG. Take care.